Welcome students to Chapter 5, which is covering anxiety, obsessive-compulsive, and related disorders. And so in this chapter we're going to be talking about fear and anxiety and the different disorders that involve those. Fear is the central nervous system's physiological and emotional response to a serious threat to one's well-being, where anxiety is more of a response to a vague sense of threat or danger. Generalized anxiety disorder is the most common of these problems. It's a disorder marked by persistent, excessive feelings of anxiety and worry about numerous events and activities, and we'll talk about it first. All of these disorders are the most common mental disorders in the United States. In any given year, 19% of adults in the U.S. have one of these anxiety disorders. 31% of all people develop a disorder at some point in life, and only 42% seek treatment. For generalized anxiety disorder, as I said, it involves excessive anxiety, and it's experienced under most circumstances. So one anxiety is replaced with another, with another, with another. There can be worry about practically anything that reduces quality of life and affects about 4% of the population. From a sociocultural perspective, GAD is most likely to develop in people who are faced with dangerous social conditions or highly threatened environments, and that's supported by research findings. Some forms of societal stress, such as poverty, race, ethnicity, and widespread illness, can produce GAD. And from a psychodynamic perspective, there is a treatment called free association for GAD, where the therapist just asks the patient to talk about what comes to mind, and then they interpret that. Or they may interpret transference relationships between the therapist and the client, resistance or dreams, and the whole goal is for Freudians to focus less on fear and more on control of the id, or the drives that are creating issues for us. Object relations therapists attempt to help patients identify and settle early relationship problems, and short-term psychodynamic therapy has been found to be more effective than longer treatments. There is humanistic treatment for GAD, but client-centered therapy that shows unconditional positive regard for clients really hasn't offered a lot of strong support for healing in this area. There's really only limited support in general for Rogers' explanation of abnormal behavior, including GAD. However, there is strong support in the cognitive behavioral area for treatment. In this area, problematic behaviors and dysfunctional thinking are thought to cause the psychological problems. And treatment focuses on the nature of the behavior and the thoughts associated with them. Ellis was an early researcher that looked at maladaptive or basic irrational assumptions, and Beck followed along and looked at silent assumptions that we make about things that produce problems for us. Cognitive behavioral therapies include Ellis's rational emotive therapy, as used widely, that looks at changing maladaptive assumptions. And then more recently, mindfulness-based cognitive behavioral therapy, such as acceptance and commitment therapy, breaks down worries and looks at things like mindfulness meditation to help people feel better. Biological explanations for GAD look at fear reactions that are tied to brain circuits. And those hyperactive brain circuits may be related to generalized anxiety. Benzodiazepines are a primary drug of choice. They provide anxiety relief by increasing the neurotransmitter GABA, which inhibits the message that ends firing of the neuron receptor. So benzodiazepines are certainly commonly used. Phobias are another subcategory that we're going to look at in this chapter. Phobias differ from fear in that they are more intense and persistent. There's a greater desire to avoid the feared object or situation with a phobia, and it creates stress that interferes with functioning. Specific phobias involve yearly symptoms that exist in 9% of all U.S. people. There's marked, persistent, and disproportionate fear of a particular object or situation that lasts for at least 6 months. There is another type of phobia that is called agoraphobia, and it includes about 1% of the U.S. population having yearly symptoms. Agoraphobia is a pronounced, disproportionate, or repeated fear of being in at least 2 delineated situations and avoidance of those. But many times people develop more and more fears such that they can even become afraid of leaving their homes because there's so many things they're afraid of in the environment. So it can be pretty debilitating. In terms of phobias, we know that fears can be learned. One of the ways is by classical conditioning, which is a process of learning in which 2 events that repeatedly occur close together in time become tied together in a person's mind and so produce the same response. An example is, let's say you're entrapped in a flooding situation. That would be called an unconditioned stimulus, or US, that produces an unconditioned response, or UR, of fear. Then you may develop a conditioned stimulus of running water, and that just triggers the conditioned response of fear. So every time you hear running water, it produces fear for you. We know also that modeling or observing people that are afraid of things can produce fears in us. And that's another way that we learn fears. There's a behavioral and evolutionary explanation for phobias because some are more specific and fear-producing than others in certain species. So this explains why some phobias in humans, like snakes and spiders, are more common than others for things like fear of meat or houses. Treatments for specific phobias oftentimes involve actual contact with the feared object or situation, but most of the time this is a systematic desensitization process that involves relaxation training first, where you get very relaxed. There's a fear hierarchy that's developed, so you may first, imagine the thing that's feared. Then you may look at a picture of it. Then you may have it in the room with you before you actually have actual contact with it. This is what's called in vivo desensitization. Some types of desensitization are entirely covert, though, all done within the imagination. And virtual reality technology can support that type of covert desensitization process. Sometimes we have problems with desensitization, and so flooding is used where the actual feared stimulus is just introduced right away. It does work, but there's a lot of anxiety associated with it, so it's not used very commonly. And then modeling can be used. In addition to having fears developed through modeling, we can use modeling also to help people reduce their fear. Social anxiety disorder is another subtype of anxiety disorder. Yearly symptoms exist in about 7% of the U.S. population. This involves a pronounced, disproportionate, and repeated anxiety about social situations in which the individual could be exposed to scrutiny by others. It typically lasts 6 months or more, and there's lots of fear of being negatively evaluated or appraised by other people that reinforces over and over again the social anxiety problem. Treatments for social anxiety address two distinct features: these overwhelming social fears. Medications and cognitive behavioral therapy that we've talked about already can be used, and also lack of social skills can be addressed with social skills training and assertiveness training. Another type of subtype of anxiety disorder is panic disorder that involve panic attacks, where there's short bouts of panic that occur suddenly, reach a peak within minutes, and gradually pass. They feature at least 4 of the following symptoms of panic, such as heart palpitations, tingling in the hands or feet, shortness of breath, sweating, hot flashes, cold flashes, and others that you see here on the slide. People sometimes believe they're having a heart attack and they go to the emergency room, but it's all anxiety-based. Panic disorder affects 3% of the U.S. population, and these unforeseen panic attacks occur repeatedly for people, and one or more of the attacks precede either of the following symptoms: at least a month of continual concern about having attacks, or a month of dysfunctional behavior changes associated with the attacks, such as avoiding new experiences. The biological perspective says that panic attacks are caused by abnormal norepinephrine activity in the locus coeruleus in the brain. More recent theories look at brain circuits and the amygdala as being a more complex root of the problem, and they have noted in the research that there may be an inherited predisposition to have abnormalities in these areas. Drug therapies improve about 2/3 of patients. So drugs are a first line of defense. They function in the norepinephrine receptors in the panic brain circuit. Improvements require maintenance of drug therapy, though. Some benzodiazepines have proved especially helpful. Cognitive behavioral therapy is used as well, that seeks to correct people's misinterpretation of the bodily sensations that they experience. They're educated about panic attacks. They're taught applications of more accurate interpretations and skills for coping. And then we have obsessive compulsive disorder, which is another subtype of anxiety disorders. OCD involves obsessions, which are persistent thoughts, ideas, impulses, or images that invade a person's consciousness when they don't want them. And compulsions involve repetitive and rigid behaviors or mental acts that people feel they must perform to prevent or reduce anxiety. OCD affects 1.2% of the world population, and there is, again, occurrence of repeated obsessions, compulsions, or both. They take up considerable time, and there's significant distress. The psychodynamic perspective looks at the id and ego defense mechanisms that lessens anxiety and overt thoughts and actions. Freud said that OCD was related to the anal stage of development, but not all psychodynamic theorists agree. Treatment involves classical techniques of free association and therapist interpretation, but have little research support in this area. Short-term psychodynamic therapies are more direct and action-oriented than longer ones. Cognitive behavioral therapy has strong support. They use exposure and response prevention exercises. There's 50 to 70% improvement with therapy in this area. Biological treatments involve serotonin-enhancing antidepressants, such as clomipramine and similar drugs. Improvement in 50 to 80% of those is seen with OCD. Relapse does occur, though, if medication is stopped. So a combination of medication and CBT is most effective. And these right here are subtypes of OCD: hoarding disorder, trichotillomania, excoriation or skin picking, and body dysmorphic disorder. All of those fall under this category and can be addressed.